Okay, we're going to get started. Good afternoon, everyone. Welcome to today's presentation, The Costs of Bias in Healthcare and Public Health Policy. I'm Tanisha Williamson of UFCW Local 342. On behalf of the Minority Coalition President, Max Bruni, President Emeritus Don Cash, officers, and Executive Board, we thank you for taking time out of your day to join us for this webinar. Before we begin, there are a couple of things that you should know. One, this webinar is being recorded and will be made available at a later date. And two, there will be live Q&A during this webinar. There will be a segment-specific Q&A midway through and a general Q&A at the end. To help us keep track of your questions, we have enabled the Q&A feature located on the toolbar that you should see on the bottom of your screen. If you have a question, we ask that you include the name of the speaker your question is for and pop it in the Q&A tab and not the chat. We wouldn't want any questions getting lost among others' commentary that may be going on during the webinar. The health of our community, equitable healthcare, and positive health outcomes for minorities is of great importance to me. I am personally excited about this webinar and happy to have the pleasure of introducing our moderator, Shamika Romanak. Ms. Romanak began her 13-year membership with the UFCW as a clinical laboratory scientist. She is currently working as a Kaiser labor liaison and serves on the executive board for UFCW Local 324 in Southern California. She also participates in several healthcare equity, inclusion, and diversity councils in the Southern California region, and strives to empower labor to lead through action so that we can move towards positive change in the communities we serve. Please join me in welcoming Shamika Romanak to the platform. Hello, Shamika, and welcome.
Thank you, Tanisha, for the warm and welcoming introduction. Hello, everyone, and welcome to the Costs of Bias in Healthcare and Public Health Policy, a discussion about the painful price minorities pay for health and paid leave inequities. UFCW Minority Coalition is excited to bring you this educational healthcare webinar, and we hope you acquire knowledge that can potentially be of use to you, your members, your family, and your friends. Today's webinar will cover a range of topics meant to provoke, educate, and empower our communities to take action towards changing the trajectory of healthcare for minorities. We will discuss factors that exacerbate healthcare disparities such as implicit bias, lack of paid leave, and healthcare coverage gaps specifically for the Medicaid underinsured population. We will also uncover some heavy truths today and ways in which we can work to alleviate the burden of healthcare bias on minorities to rebuild a system where we all can thrive. So we're going to dive right in. So when we mention healthcare disparities, what is it that we mean? Healthcare disparities are the preventable differences in the burden of disease on a population and the opportunity to attain that optimal health. These imbalances are results of social, economic, political, and environmental factors that are referred to as social determinants of health. In other words, healthcare disparities are differences in health and medical conditions that are linked to social or economic disadvantage. Historically, healthcare disparities have been linked to discrimination or exclusion. When a particular group of people do not have the same kind of access to healthcare, education, or healthy behaviors, it creates gaps in their health compared to other populations, which often persist for generations. Many of us have fallen into the misconception that the disproportional effects of illnesses are results of our DNA, our genetic makeup. I want to restructure that belief into one that is data supported and factual. It is important to note that genetics and biology are not the sole causes of diseases and health conditions disproportionately affecting minorities, but rather systemic racism and the impact of social determinants of health. Despite the advancements made in technology, healthcare, and education, the color of a person's skin plays a considerable role in their wellness, quality of health, risk of disease, and possibly death. So we're going to take a look at these social determinants of health. I've mentioned healthcare disparities are tied to social determinants of health, but let's look at how each one of those impacts health specifically. So first, we have economic stability. Those with lower incomes have trouble affording things like healthy foods and healthcare. Next, we have healthcare access and quality. In discussing access to healthcare, it is important to highlight the value of access to primary care, which is the source of care that detects and treats diseases. Primary care is key to staying well, as the focus is prevention and maintenance. So similar to how you would service your vehicle to ensure that it does not break down. Those who have access to primary care have less risk of experiencing death from cancer, heart disease, and stroke because they are routinely monitoring their health and have a streamlined method of receiving care when it's needed. We also have education access and quality. People who have access to quality education throughout their lives tend to stay healthier than people who do not. Not only does education give individuals a chance at upward mobility, which places them in better financial circumstances to access quality healthcare, it also keeps them better informed about how to take care of their health. For example, an individual with a college degree may have better skills to evaluate conflicting or complex information that they read on the internet about how to care for their prediabetes or any other disease. Now, I know we're all guilty of using Google to self-diagnose, but not all have the education to understand what it is they are reading or what to do with the information they have obtained. In addition, someone with less formal education may be less prepared to decide between reliable and unreliable information. Less education is linked to lower income, which is linked to poorer health. Numerous studies show that people in lower socioeconomic situations experience more obesity, asthma, diabetes, heart disease, and other health problems than people in better financial circumstances. We also have neighborhood and environment. Environmental contaminants in the air or the water, along with violence and crime in the neighborhood, are contributing factors to declined health. While breathing in pollutants can affect your physical health, living in an environment filled with violence has negative effects on one's mental health as well. Lastly, we have social and community context. The interaction between an individual and their family, their friends, and the community can contribute to health outcomes, but more importantly, how that community interacts with them can impact their health in irreversible ways. Structural racism has been identified as the root cause of social determinants of health and racial health disparities. So as we move through our discussion today, I would like you to keep your focus on healthcare access and quality. So this list shows several diseases in which healthcare disparities for minorities are found. However, it's not an all-inclusive list. I'd like us to look at some statistics of these diseases to really get a grasp on the gaps that exist. For diabetes, the Black population is 60% more likely to be diabetic and 2 times as likely to undergo leg, foot, or amputation due to the disease. As far as stroke, the impact is 40% more likely to die from stroke. HIV, 9 times more likely to be diagnosed with HIV and 8 times more likely to die from it. Are you still breathing? When it comes to maternal mortality, Black females are 2.5 times more likely to die during pregnancy, and Black babies are dying at double the rate of white babies. Furthermore, Black babies are 3.8 times more likely to die from low birth weight complications. When it comes to heart health, 60% of Black Americans have heart disease, with heart disease-related deaths being highest compared to other racial and ethnic groups. But there's more, so stick with me. In regards to cancer, the Black population faces the highest cancer burden with the lowest survival rate than any other population. Black women are 41% more likely to die from breast cancer than white women. Similarly, when it comes to cervical cancer, Black women are 2 times more likely to die. In the Black male population, they are 73% more likely to develop prostate cancer than white men and twice as likely to die of it. There are large disparities in health screenings in the Black population, partially due to healthcare access, trust of the healthcare system, and bias, which we are about to touch on. But this screening disparity reflects in the increased percentage, 20% to be exact, of the Black population in developing colorectal cancer. Both Black men and women are more likely to be diagnosed with lung cancer at a younger age, with Black men being 12% more likely to be diagnosed compared to white men. A blood cancer called multiple myeloma is also twice as common in the Black population than in the white population, adding to the already existing burden. So there is this burden on healthcare and wellness for the Black population. And then in 2020, COVID-19 hits. And if the light bulb wasn't already on, it's definitely on now. COVID-19 highlighted healthcare disparities for Black individuals. Blacks were 3 times more likely to be admitted compared to white individuals. Blacks died at 2 times the rate. And Blacks faced challenges when it came to getting vaccinated. There was hesitance due to mistrust, which is rooted in historic injustices involving vaccines. It took about 2 years for the vaccination rate of Black Americans to catch up to the rest of the population. So I've mentioned a lot of statistics, and I've magnified the disparities so that there is awareness of the healthcare gap that is influencing undesirable outcomes for the Black population. It is understood that social determinants of health contribute to healthcare disparities, but there is another component that needs to be part of this conversation, and that's implicit bias. Implicit racial bias in healthcare involves healthcare professionals making judgments and decisions about a person's medical care and treatment that are fueled by their own unconscious stereotypes and prejudices. Studies have found Black patients are viewed as less intelligent, less able to adhere to treatment recommendations, and more likely to engage in risky health behaviors compared to white patients. Next, I'm going to show you a short video produced by Harvard University's Outsmarting Human Bias program. I think you will find the content thought-provoking, but allow it to challenge your thoughts as we move through this presentation.
How do you know if a face is alive? For most of us, this isn't a hard decision. Take a look at this face. Is it alive? Can it feel pain? It should take a fraction of a second to decide. Of course not. That's a Ken doll in his 50s. It's not a real human. It can't feel pain. It doesn't have a mind. So here's the more interesting question. Where is the tipping point? Just how human does this face need to be for us to start thinking, okay, there's a mind in there. This face can feel pain. According to psychologists at Dartmouth, the average answer here is about 67%. Once a face is about 67% human, it looks alive, it looks like it has a mind, and it looks capable of feeling pain. But this threshold isn't set in stone. Research shows that if the face in front of you is somehow not like you, let's say it's a student from a rival school, someone who has different politics, or even someone from a different racial or ethnic group. These faces, the faces of outgroups, now have to be significantly more human than an in-group face before you're willing to say they can think or feel. This isn't a conscious decision. It's an implicit bias in perception, ticking away in the background of our minds. And there's a natural question that follows. If it's harder for us to see some faces as capable of feeling pain, could this make harming them easier? Even when we're looking at people who are undeniably 100% human. It's possible. NFL injury reports have shown that Black football players are deemed okay to play more often than white players with similar injuries. And in healthcare, hundreds of analyses show that Black Americans are less likely to receive pain medication than white Americans reporting the same level of pain. This is true in big cities and small towns, across socioeconomic class, and for many different kinds of pain. It's even true for children suffering from appendicitis.
Essentially, what we found was when children were presenting with similar levels of pain, Black children had 80% lower odds of receiving opioid medications compared to white children.
The simple truth is we see some people's pain differently. Psychologist Kelly Hoffman and colleagues found that many of us, including medical personnel, implicitly hold the false idea that Black people feel less pain than white people. From simple paper cuts to slamming a hand in a car door, the same injury was judged to be less painful in her experiments when it happened to this Sam rather than this one. And this is a bias that affects more than just how we see others' pain. It can also impact how we treat it. The medical students and residents who showed the greatest bias when they did this task were not only more likely to endorse false statements, like Black people have thicker skin than white people, they were also more likely to make inaccurate treatment recommendations for Black patients. Now, remember, these experiments aren't studying explicit bias. After all, these are doctors, a population of people who have pledged to do no harm. But no matter who we are, hidden biases in our minds can influence what we see and then how we act. So let's talk about.
Okay, so some of you may have been surprised by what you learned by watching the video. Where do you think you would fall if you had to give a percentage of how human a face would need to appear for you to consider it actually human? Would that be different for someone who looked more like you? Could you even answer those questions? The thing is, implicit bias is unconscious, meaning it is unintentional and you are unaware that it is even occurring. The tragedy is, in healthcare, these biases can lead to a host of disparities in treatment recommendations, expectations of therapy adherence and pain management, while contributing to reduced patient-centered clinical interactions and less effective care overall. Listed here are a few of the effects of implicit bias, but the impact goes beyond the hospital room. It bleeds over into other aspects of one's life, which can be a catalyst to a downward cascade. For example, healthcare disparities create this population that is more sick, which may require more time away from work for medical care or recovery. And there are a host of issues with that, which will be discussed by our speakers later in this webinar. Then we throw social determinants of health in the bucket, specifically healthcare access and quality, and now we compound it with structural racism. Implicit bias and structural racism create this vicious cycle. The U.S. National Academy of Medicine notes that unconscious bias, stereotyping, and prejudice may play an important role in persisting healthcare disparities. One of the root causes can be found in medical training and in medical science. Darker skin tones are significantly underrepresented, while lighter skin tones are overrepresented in dermatologic text, general medical text, and in scientific literature. This example serves as a clear illustration of institutional or systemic racism, defined as a systemic failure of an institution to offer suitable and fair services to individuals due to their race, culture, or ethnic background. This isn't always intentional or explicit, but often emerges through unconscious biases, ignorance, carelessness, and the perpetuation of racist stereotypes. The image shows us how implicit bias and structural racism creates a vicious cycle outside of the hospital room, leaving minorities to bear the consequences. So for example, the structural inequities inherent in our public school funding exacerbate educational disparities. Students in affluent areas, often predominantly white, benefit from well-funded schools offering rich educational experiences and a plethora of extracurricular activities. Conversely, students in neglected neighborhoods, frequently communities of color, attend under-resourced schools with limited academic and extracurricular options. When these students struggle academically, their difficulties perpetuate harmful stereotypes regarding their intelligence, parent involvement, and work ethic. This vicious cycle of structural inequity produces unjust outcomes, reinforcing damaging stereotypes about students of color and those from low-income backgrounds. These stereotypes are then used to justify discriminatory practices such as setting low expectations, academic segregation, and punitive discipline within schools, and the cycle continues on and on. Making progress in transforming the cycle from a vicious one to a virtuous one will require us to both mitigate our own biases and change structures, especially in the areas of policy implementation. So, what are some necessary changes that we can consider? Reducing disparities is going to require national leadership to engage a diverse array of stakeholders. We need to coordinate and align with federal departments, agencies, offices, non-federal partners. It will require implementation of effective policies and programs with systems in place to ensure accountability, first and foremost. We must view policies that impact health disparities through an equity lens and ensure that future policies are implemented to change that trajectory of healthcare outcomes for our minorities. Analyze structural barriers, present and historical, that need to be addressed to best serve different populations at different levels and within different contexts. Explain that policies, programs, practices, services, environments, they all support health and that working together can work to reduce health inequity. Develop a health equity plan. Emphasize the value of ensuring that everyone has equal opportunity for health and that reducing disparities contributes to the common good and benefits of all. There is so much work to be done, but it can be done, and we can get it done together. My goal was to set the tone for the remainder of our discussion today, as we have some great speakers that will be building on this topic. I'm now going to hand it over to Sandra Lee Williams to introduce our next speaker. Sandra is a devoted labor and community activist. She is the Deputy Political and Community Engagement Director for the Retail, Wholesale, and Department Store Union and the President of Atlanta North Georgia Labor Council. A champion for racial and social justice, voting rights, criminal justice reform, workers' rights, and immigrant rights, Williams coordinates political actions, community fairs, and immigration clinics that amplify the need for change while mobilizing workers across the Southeast region. Williams works diligently with community and faith-based organizations to initiate worker-centered programs aimed at improving the linkage between services, training opportunities, and resources that ultimately change lives. Williams holds degrees from Washington University and St. Louis and Webster University, as well as a certification in labor negotiations from the University of Michigan, Ann Arbor. Welcome, Sandra.
Thank you, Shamika, and welcome to all of you that joined us today for this webinar. As you heard from our last speaker, healthcare disparities are real. We have a lot of work to do, and there are related linkages between environment, our society, education, our career, and yet more work to do. So our next speaker is going to be Erica Clemens-Dean. Erica has been working as an organizer for well over 10 years. She got into this line of work through the labor movement. She was a former UFCW member. She was organizing marginalized communities to create a better work environment and lifting their voices for better pay through establishing unions. Erica also worked with 9 to 5 in Georgia, helping to amplify the voices of workers and voters in the South. And Erica's current role as the Program and Network Director for Family Values at Work allows her to share her skills and organizing tips across this country, working with multi-state organizations to build power with members using an integrated voter engagement approach. Erica's passion for organizing young people and building power in marginalized community doesn't just end with her workday. Because I would say her workday goes 25 hours a day, 8 days a week. She's a devoted wife and mother, and with her family, she enjoys spending time giving back to the community, and through various volunteer opportunities, she makes her presence known. Erica, thank you so much for joining us today.
Thank you for having me, Sandra. Really excited about this conversation and just being able to build out, some of the work that we're doing on a national level and on the ground. So just a recent promotion, I am now the Deputy Director of Family Values at Work, which is a national organization that is focused on paid leave policies, paid sick and safe days, childcare, and we help to support and pass these policies across the country, resource and grassroots organizations in states that are not as resourced as they should be. But this conversation is something that we as a team, as well as a coalition, have been actively engaged in and talking through about the disparity in healthcare, but also what it means to be a worker in this space, right? So the disparities in wages and wealth that persist for women of color, and specifically for Black women in this space is kind of how we've been aligning our care issues. But without a significant investment it will definitely be hard to right size the wages of Black women in this country, especially in the South. And a lot of these disparities are through the root of the foundation of the value of labor, right? So like Black labor is rooted in unpaid labor from slave labor. And we know that the South's history is so deeply rooted in holding on to that slavery-based economy that they were willing to leave the Union. This has persisted because of the state autonomy to set laws and to implement federal laws. But let's be clear, where this country is making incremental steps in increasing the wages of workers, the South lags behind. Many have no state laws on minimum wages. Many are at the 725 level set by the federal government. Now, when you compound other issues like the disparity of health and how the healthcare system operates, and the fact that, in most states, we don't have paid leave. There is no federal paid leave laws for states across the country. This is disproportionately a direct impact to communities of color. It further erodes on wages. For example, the lowest wages jobs are often held by Black women, while career and income disrupting responsibilities like caregiving, right? So we don't typically go into caregiving as a career. It is a natural responsibility as the woman of the household, as women just naturally take on this role. I think about, in my situation, I am the caregiver for my husband, my mother, my daughter. It is a sandwich generation, and I actively have paid leave in my job. But what if I didn't, right? And if these paid leaves, this organization was to go away and I was to have to shift industry or shift to another employer, I think about how I will be able to continue to maintain for my family and maintain these caregiving responsibilities. But, we already know that the starting wages are behind, then being skipped over in high earning income opportunities while being held back by caregiving responsibilities, that there just isn't enough runway to even build wealth or generational wealth in our communities. But here's the thing. We need more representation in policymakers and elected officials to move beyond policy lip service to implementation, right? We also have to be mindful of following policy all the way through to implementation. Oftentimes we are not impacted because what we win gets torn apart in implementation. In all things, even where the intention is to increase impact to Black communities of color, the trickle down effect is an incremental approach is not working. It's not the scaled solution for the large problem we're trying to solve. It's not understood or very much impactful in our communities in its current iteration of things. And we have to start, building out what the public education piece needs to look like in our communities. And that's, collaboration between labor unions and community services that often goes unmatched with, the amount of energy that's put against some of these laws and some of these policies. But the idea is to really keep up with state level and local level approaches and how they intersect with federal laws to build out things like paid leave, paid sick and safe days, ways for people to actually care for themselves as well as care for their families.
Thank you, Erica. We'll ask that any questions that you may have for Erica that you save until the end. But we thank you. It sounds like it does come back to the policies that we have. And we know that there are regional differences in those policies, in that we're both in Georgia, a state that refuses to expand Medicaid. So again, thank you. Our next speaker can talk to us a little bit about those policy implications. I'm going to introduce Antrell Tyson, who is the Regional Director for the Health and Human Services Department here. In March of 2022, Antrell Tyson was appointed to serve as Regional Director of the U.S. Department of Health and Human Services for Region 4. So we are very proud that he is here in our region. That is 8 states in the Southeast, from Alabama, Florida, Georgia, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee, as well as the region's 6 federally recognized tribes that also here. I see you, Antrell. Thank you for joining us today. Much more about the work that he has done and that he continues to do with Medicaid Unwinding. But before, I just want to say, before joining HHS, Regional Director Tyson served as the Director of Business Services and Policy for the City of Atlanta's Workforce Development Agency. So when we talk about policy, this is the man to guide us and talk to us about what we can do to change policies to impact those that are actively experiencing healthcare disparities. So Antrell, thank you for joining us today.
Thank you, Sandra, for that introduction. And thank you for allowing me the opportunity to come speak with the UFCW International Union Minority Coalition. The work that you all do is so critical to the lives of every American. And it gives me great pleasure to know that among you are tens of thousands of healthcare workers who sacrifice daily to ensure the health and well-being of every American. So with that, I'd like to start by thanking you all for the work that you do. And I'm pleased to know that the Biden administration is here for you. And we are committed to passing policies that impact the everyday American and not just the chosen few. So not to belabor the reason why I'm here today, I wanted to talk to you all about a very important issue that may have impacted you or the life of a loved one this last year, which is the issue around Medicaid unwinding or redetermination or renewals. Any of these 3 terms all describe the same process of re-enrolling or recertifying the people who are on Medicaid over the past year. But before I talk to you about Medicaid renewal process, let me provide you with an overview of what Medicaid is and how it is administered in the state of Georgia. Then I'll talk to you about the challenges we faced over the past year. So, what is Medicaid? Medicaid is what we call in the government an entitlement program, which means that anyone who meets certain eligibility requirements has the right to enroll in Medicaid coverage. It also means that states have guaranteed federal financial support on part of the cost that their Medicaid program costs them, which means every individual that is enrolled in the state's Medicaid program, a portion of that cost associated with covering that individual is paid by the federal government. So in order to receive federal funding, states must cover certain mandatory population. And this includes children through the age of 18 and families with incomes below 138% of federal poverty line, which is about $35,600 for a family of 3 in 2024. Also covers people who are pregnant and have income below that 138% of the poverty line. And thanks to this administration's effort to improve maternal health outcomes, states have been able to extend this benefit for up to 12 months after the birth of a child. Also, certain parents or caretakers with very low incomes and most seniors and people with disabilities who receive cash assistance through the Supplemental Security Income Program, or SSI, are also eligible. In addition to these mandatory requirements, States may also receive federal Medicaid funds to cover optional populations, which includes people in the group that I previously mentioned whose income exceed the limit of mandatory coverage, seniors and people with disabilities that don't receive SSI and with incomes below the poverty line, or medically needy people, meaning blind or deaf, and other folks with high incomes who need long-term services and support. And again, thanks to the Affordable Care Act, non-disabled adults with incomes below 138% of the poverty line, including those without children, may also be covered. Under the original version of the ACA, it was intended to extend this coverage to all such adults in the last category. But in 2012, the Supreme Court decision gave the states the choice of whether to expand their programs or not. This is what we now consider Medicaid expansion. And states who have decided to take up these expanded eligibility requirements for non-disabled adults, we refer to them as expansion states. And as of today, all but 10 states, which includes the state of Georgia, have not expanded Medicaid to cover these additional populations. I will go more into detail about Medicaid expansion issues here in the state, but because we're currently in litigation with the state, I can't say too much about the topic. Besides the fact that 640,000 Georgians could gain Medicaid coverage if the state decided to expand Medicaid. So, what does Medicaid unwinding or renewal or redetermination mean, and how did we get here? So prior to the pandemic in 2020, most people who were on Medicaid had to reapply or recertify annually, proving that they were still eligible for Medicaid program by either showing that they were still disabled, met certain income requirements, or if they still met the age requirement if they were children. However, in March of 2020, when the secretary declared that the pandemic was a public health emergency, the federal government encouraged states not to disenroll anyone on Medicaid regardless of their eligibility status. In fact, the federal government paid states more to make sure that they didn't disenroll folks during this time, and we call this the continual enrollment condition. Therefore, states did not recertify individuals for nearly 3 years. And during those 3 years, while people were not disenrolled, millions of people lost their jobs and became eligible for Medicaid. So we saw Medicaid rolls grow to over 91 million people nationally, which was a 21 million person increase in 3 years. But in March of last year, 2023, the public health emergency ended and the states were required to go back to business as usual with recertifying every individual on their Medicaid rolls. As you can imagine, a lot has changed over the last 3 years. First, many people moved during the pandemic and had not updated their contact information. Additionally, over 21 million people who were new to Medicaid had never gone through recertification process, so they didn't know that the information that they were required to recertify or that they even had to recertify in the first place. So in March of last year, every state had up to a year, which will be ending here shortly, to recertify every individual on their rolls. But what we saw was that thousands of individuals were terminated, not because they were no longer eligible, but because they failed to meet some procedural requirement. In Georgia, where there were nearly 2.7 million people on Medicaid rolls at the start of renewals, over 504,000 individuals were terminated due to procedural reasons, while only 92,000 were terminated because they no longer were eligible for coverage. Of those 504,000 people, approximately 150,000 were children and lost coverage for procedural reasons. And this is where we are today. So What we are doing from HHS perspective, we are encouraging states to adopt as many strategies as possible to make Medicaid and CHIP renewals easier for families. In December, Secretary Becerra sent a letter to Governor Kemp asking that the governor take additional steps to ensure that children are re-enrolled and that no further children are disenrolled through the remainder of the process. And we will continue holding states accountable if they don't follow the federal Medicaid renewal requirements. But in the meantime, we are helping people get connected to coverage through the marketplace. For example, we established a special enrollment period through the healthcare.gov to make it easier for people to transition from Medicaid and CHIP into the marketplace. Through our Center for Medicaid and Medicare Coverage Services, HHS revamped the Champions for Coverage program and quadrupled the number of navigators to 1,500 certified navigators ready to help consumers enroll. They are also broadening the way that enrollment assistance and increasing funding to navigator grantees to support new requirements during the unwinding. CMS invested close to $100 million for federal marketplace navigator grantee organizations to support the 2024 open enrollment, including $12.5 million in support for additional direct outreach, education, and enrollment activities for unwinding. And in this past open enrollment period, we saw a record number of people enrolled in the marketplace. This year, over 21.3 million people enrolled in healthcare coverage through the marketplace, and that was about 1.3 million who were Georgians. This overall number is a 5 million person increase than last year. So we're expecting that many of the people who may have lost coverage through the unwinding are thankfully finding coverage in the marketplace, thanks to the work of this administration. We at HHS will continue to monitor the state's progress through the remaining days of redetermination. And we ask that you continue to help us get the word out to any family members or friends who have not yet re-enrolled in their Medicaid coverage. So to find out more about Medicaid renewal process, please go to www.medicaid.gov/renewals. Thank you for your time, and I look forward to taking any questions that you may have. And back to you, Sonny.
Thank you, Antrell. A lot of good information, folks. And I know we sometimes take for granted as union members that we have great insurance and great benefits, but we know a number of people, either in our families or in our communities, that do have a need for more information about healthcare, what they can do about healthcare policy, and also about disparities that they experience and where they can go to find out more about resources. So I thank you for coming on. Are there any questions for our area director, Antrell Tyson, before we move to the next phase? Hang on. And if anyone has any questions, please type them in the question and answer section. If not, Antrell, if I can get you to hang on for a few more minutes, we may have some additional questions at the end.
Yes, indeed. Thank you for the opportunity.
Thank you. So as we think about potential solutions and next steps, I would encourage everyone to just think in terms of, if you know folks that are in need, please utilize yourself as a resource. If you have questions more about Medicaid unwinding, we actually have a number here. You have the website. I heard Antrell give it to everyone for Health and Human Services. But those of us that live in areas where there is no Medicaid expansion, please think in terms of not only is there not Medicaid expansion, but the impact that has on SNAP benefits in our community, summer food programs in our community. So this is all linked together. When we talk about social and economically disadvantaged members in our community or even family members, we have to know that there are resources and people that are available that we can go to and talk to about those resources. But it also takes me back to comments made earlier by Erica Clemens-Dean, the change, and also by Shamika, that we need to change our policies. And so you need to think of that when we go to the polls, when we go and vote. Think about those people that are lifting up healthcare for all, those people that are concerned about maternal child health, those people that are concerned about women's reproductive health. And so with that, I'm going to ask Shamika to come on and introduce Included Health.
Thank you so much for that, Sandra. So next we have Quentin Blanton. He is the Regional Vice President of Communities with Included Health. Since 2011, Included Health has worked towards their mission to raise the standard of healthcare for all individuals and currently serves over 300 clients, including over 6 million individuals with their communities programs. I am privileged to introduce Quentin and hear more about the resources Included Health provides to our communities. Welcome, Quentin.
Hello, hello. Just want to make sure everyone can see me okay. Shamika, it looks like I'm up on the screen now. And I will be sharing my screen here. Just a quick little thumbs up from you, Shamika. If you can see my screen, I want to make sure everything is up there.
Yes, we can see it.
Okay,
Thanks.
absolutely, absolutely. So I really appreciate you, Shamika and Sandra, and the UFCW Minority Coalition for having me today. At Included Health, we've created what is the first and leading navigation and advocacy offering for historically marginalized communities. So we began initially with the LGBTQ plus community and quickly expanded to the Black community for many of the reasons that you all have heard today. And so I do want to dive right in. So we really recognize that those same barriers to care and the historical mistreatment of the Black community that we've heard today existed, and it really prompted us to seek feedback from the community itself to help to understand how to make meaningful changes. We went through the same exercise with the LGBTQ plus community when we launched our offering, and now we've gone back in 2022 and done the same thing with the Black community. So in 2022, we created the Black Community Innovation Coalition and partnered with companies to survey more than 3,000 members of the top employers across the country. Our findings reinforced that data that we heard earlier today that existed in the stats that Shamika shared earlier around the urgent need for change, but it also highlighted the need for high quality affirming providers. And so 4 main themes really emerged from this survey, which really guided the creation of the Black Health offering. We said this is an offering that was built by the community for the community. Number 1, there's an overall lack of trust in healthcare. Number 2, affirming and clinically competent care is really hard and challenging to find. I think some of the times we find ourselves having to pick up the phone and call a relative or a friend or someone maybe that's in the industry to try to get a recommendation for an affirming provider. We recognize that as a challenge. Next, we saw that the healthcare system is confusing. People really don't understand what's available to them. and all of which leads to this tendency to avoid care, which ultimately hurts people overall health outcomes. From the survey, we also identified 3 key ways that we can make change. One of those was help members find healthcare providers who will treat them with respect. We talked about implicit bias earlier when Shamika was giving her presentation. In our data that we found more than 30% of individuals within the Black community said that they had experienced some sort of bias within the healthcare experience. There was another about 17% of individuals that said it may or may not have been biased. I'm not totally sure. So that we know that 30% number is likely much higher than what we received in the survey. The second piece is help members understand what benefits are available to them, including access to community resources and services that address social determinants of health. And third, connect members to doctors who have expertise in conditions that commonly impact Black communities. Again, just from my notes earlier today, we talked and we saw the alarming statistics around cancer, around diabetes, heart disease, HIV, Black maternal health. So we're going to give you an example of just a journey of what one of our members went through from a Black maternal health perspective. We took all of these learnings to heart and really developed this unique approach to create a community-specific and culturally appropriate health equity program catered to the needs of the Black community. So rebuilding trust in healthcare really underscores our program and is at the heart of what we aim to provide. We really want to remove the barriers to care. We want to work to help members understand the benefits available to them, not just medical, dental, but also employee access programs and community programs that can be used. For example, to connect, Black expecting parents to groups focused on preparing for parenthood and to transportation or childcare services to really ensure that you have what you need to be able to go to your medical appointments. We'll also help with the complicated parts of healthcare. So understanding costs, understanding claims, talking about pre-authorization. What is the pre-authorization? What does this mean? All of these things that might be necessary through those complicated aspects of the healthcare journey and experience. Our team of Black care coordinators are really the heartbeat of our offering. More than 85% of our care coordinators identify as Black or African American. We understand the value of the shared lived experience. I know we're not talking about LGBTQ plus health today, but on the LGBTQ plus side, more than 90% of those individuals are woven from that community. So our care coordinators, they work directly with members to identify providers based on the members' needs. Our team personally vets these providers. This is not a raise the hand exercise to say, hey, I'm affirming, and can you please include me in your directory? This is a truly vetted process. We pick up the phones, we go through the process of having phone interviews to confirm that individuals are knowledgeable about the issues within the Black community, as well as the historical mistreatment of Black people in healthcare. We also conduct post-appointment surveys to make sure that our provider database stays updated based on members' actual experience of working with the provider. So again, this is not a raise your hand and you're in the network and you're in the network or directory forever. No, this is a continuous loop of engagement with those providers to ensure that they remain affirming and clinically competent to be able to serve our members. Black Health today supports more than 1.5 million covered lives. And one of the ways we measure success is through feedback that we get from those members themselves and our incredibly high member satisfaction, as well as provider satisfaction ratings tell us that the work that we're doing is really working. In fact, 9 out of 10 of the individuals that engage with us say that they are less likely to avoid care because of being able to utilize our included health communities offering. So here on the screen, these are just a few examples of the kinds of requests our care team is fielding on a daily basis. We're identifying providers. That's a huge part of what members need, but the true breadth is actually much wider, much bigger. We're focused on supporting the whole person with end-to-end care with both the LGBTQ plus and Black communities. And then our services go much deeper than our competitors that are in the marketplace, who often just kind of stop at this idea of a directory search or communications during a Heritage Month that can sometimes fall flat. So I won't read all of these, and I know that this will be provided on the tail end, so you'll get an opportunity to dive deeper. But one of the areas, as an example, mental well-being. I had someone approach me about this at a conference, at a diversity, equity, inclusion conference a couple of weeks ago. And mental well-being was one of those areas. They said, my teenager is struggling, but is worried his friends will judge him if he's in therapy. How can I help him to see that this is a strength? And then from a family building perspective, I was dismissed and denied pain medication during my last pregnancy. Where we can find an affordable, where can I find an affordable Black midwife to support me through this one? These are some of those questions, some of those experiences, and it's very sad. Like, we hear about the maternal health crisis that exists, the Black maternal health crisis that exists in this country. I mean, we just had another example of it. I'm not sure if anyone saw, but the Kansas City chief cheerleader just passed away. Former cheerleader just passed away. A young Black woman who had just gone through childbirth and passed during that childbirth experience. So this is not just about individuals who may be in the rising or high risk categories. This is across the spectrum, and it's something that we need to continuously focus on, something that we need to continuously keep top of mind as we work through this process of solving this crisis. So as I mentioned, I wanted to walk through a quick example of what it looks like to receive support from our Black Health Program. So here in this case, Michelle is a newly pregnant mother of one whose past experience with the discriminatory OBGYN is making figuring out a birthing plan team feel really overwhelming. So this is where we get involved. So it starts with engagement and onboarding. Michelle, she learns about our Black Health offering through her health plan, reaches out, and is connected to Kiara, who can relate to Michelle's concerns given her own experiences during pregnancy. Then education and benefits guidance starts to kick in. Kiara shares educational content on pregnancy for Black bodies, including information on different types of providers covered by Michelle's insurance. There we go through this process of provider matching. Kiara actually researches and vets affirming in-network clinically competent midwives and OBGYNs that meet Michelle's needs across preferences, convenience, and clinical specialization. The onboarding process of our community's offering allows Michelle to really be specific about what her preferences are through her journey, and our care coordinator, Kiara, has the opportunity to take a look at those notes in order to find that right provider. From a community connection perspective, Michelle then feels lonely and wants to talk to people in similar situations. So Kiara researches a local community of expectant Black parents and refers Michelle to that. From a policy guidance perspective, we talked a little bit about that earlier as we talk about ways in which people are able to engage their employers through this policy aspect of things. So Michelle's OBGYN uncovers that there are clinical complications and then addresses them quickly, but it requires Michelle to start her leave early. So Kiara, our care coordinator, guides Michelle through that workplace medical policy process, making it easy to follow through with that doctor's advice. And then finally, from a benefit and care navigation, it doesn't just stop when Michelle gives birth. Michelle gives birth to a healthy baby, but after which her care coordinator continues to check in on her and make sure that she's okay. Kiara then learns through those conversations with Michelle that she's been diagnosed with postpartum depression. And so now she kicks in and Kiara is there to help her to find an in-network therapist. These relationships with our care coordinators are longitudinal in nature. It doesn't stop at just this one experience. Each and every time Michelle would engage our care coordinators, she would get Kiara as her care coordinator through that process, improving that trust, improving that experience, and helping to navigate and keep Michelle on that right path. So I'll stop there. I know I only had a little bit of time, and I'm excited to answer any questions that there might be about the included health community offering, but I wanted to leave this as a takeaway, and you'll have this at the end of the conversation. Thank you so much again. I really appreciate the time. And Tanisha, I think I'm handing it back over to you.
Yes, thank you, Quentin. That was a great presentation and a great offering of resources that Included Health has. And listening to you speak, I couldn't help but to think back that implicit bias, as Shamika stated in her presentation, tends to be unintentional and not recognized by the provider, but it definitely is felt by the patients at the time when they're experiencing it. And definitely associated with that medical distrust and some of those statistics that Shamika touched on, which, can lead to, those negative experiences and people, being hesitant to seek the care that they need, which in turn leads to undiagnosed or misdiagnoses, which if they had received that care and treatment sooner, maybe the outcomes would be different. So this is important information and a great tool and resource that Included Health offers, and we thank you for your presentation today.
Absolutely. Thank you.
Thank you, Jen.
So let me just check the Q&A to see if we have any questions, because now is the time that we are opening it up for any questions that you may have for Quentin, Sandra, Shamika, and I'm not sure, is Erica still with us? Okay, let's see. Okay, so we have one question for you, Quentin. It says,
Yep.
so is that Included Health program another network of providers, or are they part of our existing network? And that's from an anonymous attendee.
Yeah, no, absolutely. I can answer that question. So our directory is totally separate from your existing network. If you were to, put Included Health in place with our communities offering, our directory is proprietary, and we've gone through and vetted that. So then what we would do is we layer on top of your existing network. So we would look at the existing in-network providers based on your existing health plan. And then we would match that up with our provider directory, and we would look to find those connections for those culturally affirming, clinically competent providers that are also in network for the member. And then we would lift up multiple options and ultimately help to guide that member through that process, including setting up appointments and doing any sort of follow-up after those appointments. If the member has preferences for a provider that doesn't happen to be in our directory already, we'll go through that process of picking up the phone and handling that vetting process right then and there. And if that provider ends up being someone that is affirming and clinically competent, then they would then be added to our directory as an additional resource and provider. But great question. I hope that answers the question.
Thank you, Quentin. I see another question, a little similar to the one that was just posed, but it looks like, Shamika, you want to take this one? And
yeah, I'm going to hand it over to Quentin, but the question is from Andres Pinzon. Is this a healthcare plan we would attempt to have union employers adopt into our existing contracts? And I'm just going to add a little bit to that. I just want you to add how that relates to labor, like UFCW world, and how your service and your resource can be adopted.
Yeah, absolutely. So we absolutely could be included as a part of the existing contracts. We are not today. I want to be clear about that. We are a resource that anyone could reach out to us to potentially implement within their locals, or as we have these conversations, further relative to UFCW as a whole. We would love to, be there and be offered as a solution. But for right now, the process would be to reach out to myself and or Matt, who's on our team, who's on that slide, and we can have a one-on-one conversation of how we could potentially serve your members. So it is separate from what you have in place today, and certainly would be open to having that conversation. Shamika, am I good there? Anything else you need to add?
No,
Okay.
that's perfect. Thank you.
And then I see the next question from Alma, and I'll just go ahead and answer that really quickly. Included help is available in all states.
Thank you. And I see that Antrell has rejoined us. We did have a question that came up during your segment, and it's not showing up now, but I do remember it. And the question was, is it true that the states that have not expanded Medicaid is also right-to-work states?
Wow, great. That's a great correlation. And I think that there's a very close correlation between right to work states and expansion states. We have not identified the direct correlation. However, through leadership, we can understand what leadership value when it comes to working population and the people of those states. So I think that is a very accurate assessment. But as far as why that is the case, I think that has a lot to do about state leadership and the decisions that they make in helping the citizens of their states.
Okay, thank you. I don't see that we have any other questions waiting in the Q&A. This is the last call for anyone that has questions. If there aren't any other questions, I'll turn it over to Sandra and Shamika for any final words or takeaways.
Thank you, Tanisha. I just want to say very quickly, our area director was very political in his response. In answer to that question, they absolutely are Southern states that are right-to-work states that don't want to expand Medicaid, that don't want to expand care in the populations that need it the most, which is why I make a plea to everyone. If you haven't registered to vote, please do. When it comes time for the election, which we are in an election season now, please consider that when you make your decision at that poll. And thank you again for joining us. We will have another great episode of the Minority Coalition coming to you in the next few months, I'm sure. Shamika, that's all I had.
Yeah, what I could say, how.
Yes, excellent point, Sandra. I'm so glad you brought that up. Please make sure that you are registered to vote. And not only that, that you actually get yourself to the polls and make sure your voice is heard. Your vote does count. I hope that today you were able to take some things away. We talked about some things that were sensitive. We provoked you a little bit. And that's good because that means that action can come out of it and change can come out of it. And we need to engage those who have power to implement policies so that things can be different for all of us. It was a difficult conversation, but it was very enlightening today. And I really hope that you took something away that you can take back to your membership, back to your friends, back to your family, and hopefully we can change that trajectory of healthcare and that gap that we have for everybody. So we hope you leave empowered and educated. And like Sandra said, this is only the beginning. There's going to be more. And we really thank you all for taking the time out of your day today to join us on this webinar that the Minority Coalition has brought today. Thank you all.
Thank you, Shamika and Sandra. This brings us to the end of today's webinar. Thank you to all of our presenters, Erica Clements-Dean, Antrell Tyson, Quentin Blackson, and our wonderful moderators, Shamika and Sandra, and the Minority Coalition Planning Committee for putting this together. Thank you all for attending and participating in our Q&A. Enjoy the rest of your day. Until next time. Bye, everyone.